Hey there, this is Dr. Kayla White, and I'm going to be discussing medullary thyroid cancer. Looking at the description of medullary thyroid cancer, it accounts for 1 to 2% of thyroid cancers in the United States. Medullary thyroid cancer is different from other types of thyroid cancer. Other types of thyroid cancer usually derive from thyroid follicular cells, or the cells that make the thyroid hormone. Medullary thyroid cancer differs because it originates from the C cells of the thyroid gland. Patients with an inherited form of medullary thyroid cancer usually have a mutation in a gene called the RET proto-oncogene. And this mutation is present in all the cells in their body, and these mutations cause the development of medullary thyroid cancer. This is important because in family members of a person with an inherited form of medullary thyroid cancer, a blood test for the mutation can actually lead to an early diagnosis of medullary thyroid cancer and a curative surgery, hopefully, to remove it. So looking at assessment findings, it usually presents as a lump or nodule in the thyroid. It may be noted by the patient or discovered during a routine neck examination by your physician. Patients with advanced medullary thyroid cancer may actually complain of pain in the neck, jaw, or ear. If a nodule is large enough to compress the windpipe or the esophagus, it may cause difficulties with breathing or swallowing. Usually more aggressive than other more common types of thyroid cancer, and it's usually easier to treat and control if it's found before it spreads to the lymph nodes in the neck or other parts of the body. Also, part of the diagnostic methods, a diagnosis of thyroid cancer is usually made by a fine needle aspiration biopsy of the actual thyroid nodule or after the nodule is surgically removed. Patients in whom the results of the biopsy are suggestive or indicative of medullary thyroid cancer, they should be further evaluated with measurement of the proteins, calcitonin, and your CEA in the blood, which are typically elevated. So looking at the pharmacologic treatments, the primary treatment for medullary thyroid cancer is surgery, and the current accepted approach is to remove the entire thyroid gland or a total thyroidectomy. After surgery, patients need to take thyroid hormone replacement medication for life. New chemo agents that have shown promise treating other advanced cancers are increasingly available for the treatment of these thyroid cancers. So those NIB cancer drugs, the NIB at the end, they have been FDA approved for use by patients with medullary thyroid cancer. These drugs do not cure advanced cancers that have spread widely throughout the body, but they can often slow down or partially reverse the growth of cancer. Non-pharmacologic treatments, follow-up visits, very important. They include a careful history and physical, that thorough examination, paying close attention to the neck area. Neck ultrasounds, it's also a very important tool to visualize the neck and look for nodules, lumps, or enlarged lymph nodes that might indicate the cancer has returned. TSH, or your thyroid stimulating hormone, should be checked periodically, and their thyroid medication adjusted to keep those TSH values in normal range. Measurement of calcitonin and CEA, as we talked about before, are a necessary routine part of follow-up appointments with patients with medullary thyroid cancer. Following a thyroidectomy, it is hoped that calcitonin levels will be essentially undetectable for life. A detectable or rising calcitonin level may raise suspicion for possible cancer recurrence.